Hello, everyone, and welcome to the webinar today. My name is Linda. I'm better known at the Reeve Foundation as Nurse Linda. So if you see something from the Reeve Foundation, Nurse Linda, that would be me. I just got back from Florida, where I was at the Fort Lauderdale Abilities Expo. If you get a chance, the Abilities Expo comes to your town, that's a great program to attend. They have lots of people there with all kinds of things that would be helpful to your condition, be it equipment or healthcare information. The Reeve Foundation generally has a booth there. And then there's workshops, and I get to speak at one of the workshops. So that's always a lot of fun. And it's just nice for me to go because I get to meet a lot of people. Some people who know me and they'll come look for me, and that's very exciting, for just a regular person, it's like, oh, you know who I am. It's always a shock to me. Um, so I don't have that kind of celebrity makeup in my body. But anyway, I am a middle-aged woman, fair skin, brown hair. I'm wearing clear glasses today. I have on a multicolored shirt and I have my beautiful Reeve professional background. So I just love having that. And I want to say thank you to the people who are helping us today, Kelly and Donna and Krista, who's doing the ALS interpretation. You can see her there. We have a closed captioner on, and there's a lot more people that are working behind the scenes that make these programs happen. So we always appreciate when you tune in. And again, I'd like to say welcome. We have a lot of things to talk about today. So I'm going to jump right in. First of all, I want to mention we have a friend in the community, Kimberly Anderson, who works at Metro Health, and she is just fabulous at everything she does. And one of the things that she does is she's working on a research project. I'm going to look over to the side here because I have the flyer about it, but it's a bowel stimulation trial. So it's a clinical research project and it's short term genital nerve stimulation in individuals living with spinal cord injury. And so it's to help with bowel control, because that's one of the biggest challenges. And we're going to talk about it today because we have several questions about that. And so this particular study, if you want to participate in it, you have to be 18 years old. You have to have a traumatic spinal cord injury between cervical level 1 and thoracic level 12, so that upper motor neuron injury. Your injury has to have occurred at least 6 months ago, and you have reflexes in the pelvic area when tested by a doctor. So if you qualify for this study, and this is great because I know a lot of people would really want to participate in this, but if you qualify for this study, um, you'll receive the stimulation. You'll need to complete 1 to 2 in-person evaluations at the Metro Health Center. Um, and it will be lasting up to 6 to 7 hours per session. I don't know if they'll be stimulating that whole time or if it's stimulation and then rest. I don't know. But if you're interested, you can get more information about it. And you will see the information that will be popping up, who to contact in just a moment in the chat box there. Also, if you decide to participate, you receive some compensation for your time and assistance with travel. And I understand that they have a place where you can stay overnight if you're traveling from a distance and can't get there real quickly. So, a lot of people are interested in all different kinds of things. Some people want to participate in clinical trials, and if you're of that mindset, this might be an opportunity for you. So, I urge you to please call and find out more because, if we get people that are able to do these things, do these studies, that helps everyone. So for right now, it's a limited number of people, limited diagnoses. But if they have success with this, that they'll move it to other populations and all this over time. So something very interesting to find out about. So we have a couple of people that have written in some questions when you hit that Nurse Linda Blue button on the Reeve website. And the first one is about a person who's having issues with their gut. They had a colostomy in 2014, and he's not able to eat any sodium or fat because when he has a cookie or a snack, he has this bloody discharge. Well, I say he, it could be a female. I'm not identifying these people. I'm just saying he in general. Um, he has a bloody discharge from his rectum, and it's been going on so long that he's really losing faith in living, which is really always is something that really gets gets to me because we've got so much to live for and there's so much to do. But you can understand how this problem ongoing since 2014, my goodness, this is going on quite a long time. And I'm sure that this person has probably discussed this issue with their doctor. And if not, just keep bringing it up and keep bringing it up and say, it's not getting better. So be sure and bring it to their attention because, losing blood can be very, that can be very detrimental to your health. Now, when I read this, the first thing I thought, no, oh, first of all, I want to say this is following a colostomy. Some people have discharges like this even without colostomy from the neurogenic bowel. And so I'm assuming that this person has a neurogenic bowel. They didn't particularly mention that, I don't think. But anyway, colostomy, I am not for them. I'm not against them. I want to make that clear. You have to do what is the right treatment for you. I just like to educate people. There are many, many people who have colostomies and they say it's the best thing they've ever done in their life. And they really become advocates for colostomies and they want everybody on board. Colostomy in the spinal cord injury population and those with neurological disease is really becoming uh, um, a medical kind of alternative that is being offered more and more. However, there are problems that can arise with colostomy, and that's what I want people to be educated about. I think sometimes people get lulled into hearing other people say, "Oh, it's so fabulous. I had a colostomy. It was, I don't have my bowel program anymore, and it's just wonderful." But there are a lot of problems from simple kinds of things like the bag doesn't stay on. If you look up online colostomy and you look at pictures of people with a colostomy bag on, especially from companies that make the colostomy bags, the models all have a six pack. I know very few people who have neurological injury. And in fact, I know very few people with any kind of health concern or even no health concerns that have a six pack. So sometimes getting those bags to stay on is that's a challenge, but that's kind of more one of the easier challenges. This person has a very serious complication from their results of their colostomy. Now, sometimes the in the colostomy, it's a surgery which people who have neurological problems can have issues having surgery. It's difficult to get off the ventilator because breathing is impaired, and there can be a lot of complications there. But the first thing I thought about was with the sugar, if you have this bloody discharge, could it be that you have diabetes? So be sure and check to see, have your blood sugar checked to see if you have diabetes as a complication. Because if you have diabetes and you eat some sugar, the minute that sugar hits the bowel, boom, people sometimes with diabetes have diarrhea right away. And so diabetes is a secondary complication of many neurological diseases, including spinal cord injury. It can occur also, metabolism of sugar can be a problem with stroke or any other neurological diseases. So that was the first thing. Now, salt sometimes can act as a stimulant for diarrhea. If you think about it, enemas and a lot of preparations for that are taken orally have salt in them, not table salt. So don't be taking table salt, but they have different formulations of salt in the product, which draws fluid from the bowel wall, which can also be very dehydrating. So another issue to look at with salt causing diarrhea. But when I thought of salt, I thought salt's usually on greasy food, and grease is also another one, although grease wasn't mentioned with that. So, what I recommend to this person is to talk to their healthcare professional. If they're not having results, it's been 10 years now. That is a long time to really have to put up with this. So ask for a consultation with a bowel specialist. Sometimes, as I was starting to say, when you do a colostomy, the the bowel is cut so that one end of the bowel is opened out to the outside of the abdomen. Then, oftentimes, the lower end of the bowel is closed off. Sometimes the rectum is closed off, but in this case, that was not done, and in some cases, it is not done, and until this is completed, you have to eliminate that fluid because there are still nerves that are connecting to that bowel. So you have to release that fluid that is the blood and the secretions from that bowel. So you need to have that rectal area open now so that can come out. Sometimes they'll have a double barrel colostomy where they put both ends of the colostomy that has been cut open to the outside. So there are two openings, but there are all different kinds of treatments. Now, what you can do to try to help yourself, but talk with your healthcare professional first. This is very important because this is a very serious problem. But sometimes what they'll have you do is they'll have you to go off all sugar and all salt. And you'll have to be off of it for like say a month or 6 weeks. And that'll be hard to do because we're used to eating the foods that we want to eat. But they'll have you be off of that for a while, let the bowel rest, let the bowel heal, and then very slowly reintroduce some of these foods. But just as people with diabetes, they can't eat certain foods. If you have heart disease, you have to reduce your salt. And it may be just by not having so much of these things. I have no idea if you're overdoing it or whatever. So these are just some things to think about, some questions to ask your health professional if that would be the right treatment for you. There might be some medications. Maybe they need to do a rectal exam to look up there and see what's going on. Maybe there's some fissures in there that need to be healed up. Maybe the bleeding's from something else entirely that's going on in the bowel. Maybe there's been a polyp or something that's open and so maybe it's just coincidentally that it comes along with the food. Now, this person is writing in and they really sound like they're knowing what they're talking about, but I speak in generalities. So I'm just trying to think of some of the things that, might be helpful to this person to look into. But be sure and talk to a bowel specialist, talk to your regular healthcare professional and get that referral to the specialist. Um, there's a person who's high level quadriplegic, C4, C5. They've ended their rehabilitation. Now, I think this person lives in another country because they're interested in a procedure that's being done in the Czech Republic, which is electroacupuncture. So, acupuncture is a Chinese medicine form. You can get it here in the United States as well, and some people do acupuncture if they have neurological injury. So needles are inserted in certain areas of the body. Sometimes an electrical current is attached to this. And so they've been through this and they wanted to know what my opinion was of it. And when you have electrical stimulation of a nerve, you're going to have some kind of movement because that stimulation is being applied to the nerve, and that's the way the nerves move. So if it's an electrical pad that's being put on the skin, or if these nerves, you're going to have some movement. Sometimes it can strengthen muscles around the area of, where you're trying to seek the movement. Is it a cure for spinal cord injury? The way it is right now, no, it is not. I always think about people who are doing these treatments. You want to think, is it helping or is it hurting? This person said that they got results from it, but I don't know what the results are. But he's going to go back and continue the treatment. And he thinks maybe if he does some muscle reeducation and maybe some stem cell treatments, that this will help his condition. Well, I can't predict if it will help the condition, yes or no. I can tell you that right now there is no cure for spinal cord injury, but we have a lot of promising things that are going on with the functional electrical stimulation. Maybe this might be a part of it, but I always tell people when they have treatments that you can only go one place to get it, or you have to go, and if you have to pay a lot of money to get it, I'm telling you right now that if there was a cure, we would all know about it and everybody would be doing it because we would really like to hear more and see more of these things. So people would capture this. And so, it's something to think about. It's something to look into, but, think about how much money you have to spend for a treatment that maybe works, maybe doesn't. If it works for you, man, that's great. Sometimes stimulating those nerves, we know from the functional electrical stimulation studies, sometimes stimulating these nerves, there's some carryover, and people after the stimulation has been turned off, they will still have some carryover. So there's a lot of research that is going on and is continuing to go on. So how this compares with the surface stimulation over the skin, we'll have to see and wait that out and see how that is. So would I hope that would work? Yes, I hope it does. But right now we don't have a definitive answer on some of these things. But also be very careful what you choose to participate in, because if you choose to participate, especially in some of the transplant studies, it might disqualify you from future studies. So that might be something to consider. And the reason why I'm bringing that up is years ago, about 20 years ago, when stem cells was first coming out, it was a big thing. You could go down to Mexico. It cost a lot of money, and they put along your back, they would inject stem cells along the outside of your spinal column, just on both sides, and they would inject stem cells. The stem cells were from sharks. That's called a xenotransplantation. So you've had shark genetic material injected into your body. And so we knew at that time if you had the shark stem cells, and there was never any proof. They would say, "Well, yes, we have people, and here's a videotape of someone who had it," but it was never like in the clinical literature. It was never where researchers could study and understand and see what was going on. So if people can't produce their results, there was also a stem cells studying being done in China, but they couldn't produce any of their results because they would give the treatment, the people would go home, and then they never have any contact with them again. And they'd say, "So see, it must have worked because they never came back." Well, in China, you can't always come back and have more treatment or follow up care. There was just, and they said, "Well, we can't follow up because we don't all speak the same dialect of the language." And so it's like, well, if you don't know if it works, why would you do that? But anyway, so I just say be cautious with what you do. That's why we have in our country, we have the FDA, and if people in other countries want to do a study, they will generally follow the FDA guidelines because it is so strict, and we know that we are kept very safe. So that's a good thing. Okay, here's another question about neurogenic bowel. This person was told they'd never walk again, and they went to a nursing home in 2012. They can currently walk dependent on their walker. It's not easy. And, as I always say, we have equipment and stimulation that can get people up and walking with braces and all kinds of equipment, but it's the balance and coordination. You don't know this proprioception, you don't know where your feet are. And if you're trying to hold your body up, that's a tremendous amount of work for your upper body. So some people will elect, especially lower injury people, will elect to start out with braces. They'll do FES training. They'll do all these things, and they are able to walk. They might get one of those exoskeletons that will help them walk, and those are done now. You can get an exoskeleton now through most insurances. However, um, it's only for therapeutic use. So it's not, you can go out and do a walk outside, but you have to have somebody with you, and it's only for therapy. It's not like getting up and, using it every day and those kind of things, because it is very exerting, but it has some wonderful benefits to it because you're up and you're using those muscles. It stimulates your bowel and bladder. It has many, many benefits. So you're using those muscles in your legs and abdomen so that, there's a lot of good things that come out of that. So he wants to know, are there any trials out there? And there are trials. So you can go to clinicaltrials.gov, put in spinal cord injury, and there's all kinds of things that are going. Right now, the big thing is the current big things are the functional electrical stimulation trials that are still going on, where it's a patch that's put over your back. It has electrical stimulation. There's a small stimulator that goes to it. Depending on what kind of function you want is where you place it over the over the skin above over the spinal cord. So if you want hand function, you place it up higher. If you want bowel and bladder function, walking, you would place it down lower. The devices were supposed to come out this year. There's still some problems. I don't, and nobody knows what the issues are. I think it's some complication with the FDA, but don't quote me on that one. But there's some issue what's going on. They want some more testing or something that's going on. So there's a lot of things that's going. Those clinical trial results have been published and they've been replicated by other scientists and researchers. And so this is a very promising endeavor. And I know I was all gung ho because it was supposed to come out, but it got delayed. But this is what happens in science, and we want to make sure that it's all in good form. Now, there are several companies that do it, and we'll have Donna put some information. There's a link that we have that lists all the companies that are working on these. So you'll be able to look up. The companies have clinical trials. So if you go onto their website, you might be able to participate in a clinical trial in those, so that would be a good place to go for clinical trials in walking. Here's another question about bowels, and there's a person who has a healthcare worker that comes in, and so they need to have their bowel program between 6 a.m. and 8 a.m. And they want to have a bowel program without using stool softeners, without using suppositories, and without doing an enema. Enemas we don't recommend, as you know, for bowel programs because it flushes out the bowel and it teaches the bowel not to work. So we want to stimulate the bowel using suppositories to make it work, and then stool softeners, which coat the bowel, which helps the stool come out more easily. And so these are the things that we want that bowel program. If it's a suppository, it has to be put in right next to the bowel wall to work. The heat of the body melts the suppository. If you just stick the suppository in and it's not up against the bowel wall, and if it's in the middle of stool, there's not enough heat to dissolve the suppository. So it's like you've not even done it. And it's not up against the bowel wall. The medication, the stimulant that's in the suppository, can't get the bowel to stimulate to work to make it squeeze itself and to move the stool along. So it's important to do that. But if you follow a healthy diet, eat roughage, drink fluid. If you're on a bladder management program, you won't be able to drink as much as you want. But if you, you have to stay within your bladder management restrictions. But if you have uh, uh, suprapubic catheter, you can drink fluids more liberally. You don't want to overdo it because you don't want to overstimulate your heart, but you want to drink, for the average person, 3,000 cc's a day is what it comes out to be. And so, build up to it. Don't just start drinking it because you can overwhelm your heart so easily. So, but then if you do the suppository and you do the dig stim and you work with your healthcare professional, you're going to have that bowel movement every day. And so that will work out. But if you have neurogenic bowel, that's the only way that we have. Now, again, I talk about these FES stimulators, and you can get an FES stimulator that you can put on your lower back that will help with bowel function. You can get an implant if you have a lower motor neuron injury. You can get an implant where you have a little device that's placed on your abdomen, and then there's a wire that tracks around. to your sacral nerves, and those can be stimulated because those are peripheral nerves. And so those can be stimulated. And so you press a button for urine control, you press a button for bowel movement, and then there's a third option for sexual function in men. And so that's another option. If you have a lower motor neuron injury, you can get a nerve transfers, which you can move some nerves around. Or if you have an incomplete injury, you can move some nerves around again in that cauda equina where the nerves come out of the spinal cord. And so there's a lot of things that are available right now. But if you have that upper motor neuron, the FES device placed over the back, and I was just reading this morning that Spinex, which is in California, has a device called SCONE, SCONE, and that is a bowel stimulating device. So there are all kinds of different treatments. We have this Kim Anderson study that's looking at another treatment, a nerve stimulation for that. So there's a lot of things that are going on there. So some more questions. This question, oh, when I read this, it just kind of overpowered me. How do you explain to people what paralysis feels like? And that is really hard because I have never been paralyzed, so I don't really know myself. I know what people have told me. And people who have spinal cord injury can look down, they can see their body, but they just don't feel it. They can see it, they know it's there, but there's just no sensation from that with complete injuries. And the higher level, the less feeling you have within your body. If you have a lower motor neuron, you have more function with spinal cord injury in your upper body. Now, if you have neurological injury with paralysis from disease, it can be completely different. So, for instance, like with MS, you might have some nerves that are paralyzed, say in the leg, it can be anywhere in your body, but you might have some nerves that are paralyzed in the leg, but not all of them. So, you still might have some sensation, you might have some feeling. So, you might still have that proprioception about your body um, being present. If you have a head injury, sometimes people with stroke or head injury, they'll have paralysis on one side of the body, which they don't feel. Because of issues of having a stroke or head injury in the brain, it might interfere with that proprioception. So sometimes people don't recognize that if their right arm is paralyzed, they don't recognize that that right arm belongs to them. And so that's a kind of interesting phenomenon because they might be able to tell you that, would you get this person's arm off my lap? Or, why is this person sitting so close to me? Or they might not, really realize that that is part of their body. Sometimes with a stroke or brain injury, your vision is affected. It was something called hemianopsia. Now, people will say they're blind in one eye. Well, that is not what hemianopsia is. It means you're blind in one half of each eye. So you might not be able to see to the right side of both eyes or to the left eye of both sides. So we need to approach them from where they can see or put their food over to the side where they can see, because if their food is on a plate right in front of them, they'll be able to eat their food, but they'll only eat on the half of the plate that they see. If they have a glass of water and it's on the side they don't see, they won't be able to find it. Now, we try to teach them to turn their head and look around, and you'll see a lot of people with stroke will look forward. They're looking like this because this side is blind, or they'll look like this because that side is blind. So, what it feels like is you just don't feel anything. What it feels like in your heart is kind of a completely different thing because being paralyzed is a challenge. There's no doubt about it. It can make people feel very sad, desolate, it can make them feel isolated. And so you really need to think about people's mental health because it can really lead to a lot of depression. And so that adjustment period can be very difficult. Sometimes people don't ever really adjust to it, but you have to really learn to live with it and accommodate for it. So that I guess is about I guess that's about what I can say about that. Um Oh, there's some questions that have come in. Um, other types of modalities for chronic pain management, acupuncture, those sort of things. We have a pain management booklet. There are a lot of non-medication treatments for pain management. Acupuncture is one. Um, Biofeedback is another. Gentle movement is very, very helpful. So sometimes people, they think, well, if I move my appendage and I just, people want to exercise, they think, oh, yeah, I got to get 20 reps in because that's what you want to do if you're building muscle. But if you have pain, think about people who have arthritis. If they move too quickly, that makes the pain worse. It's the same thing with nerve pain that you get from neurological disease. It's the same kind of thing. If you move too quickly, that's going to make the pain worse. Very gentle movement helps. If you can have aquatic therapy in a heated pool and have someone move all your joints, oh, that people say that's just so relaxing and relieves a lot of that pain. So being very gentle is very, very important, that you are gentle. And there's a whole lot of tips, much, much more in that pain management book. So be sure and look up the pain management book. Everything at the Reeve Foundation is free. So there's no cost for any of that. Here's a person that had a C5 quadriplegia and the right foot turns inward, causing pressure on the outer column of the foot. They managed for many years with Botox injections, and they still get periodic breakdowns. Botox is becoming less effective, so they've been unable to wear a shoe. Wants a long-term a solution, and I shouldn't say he or she, they want to get into a shoe. And the only alternative is Achilles tendon lengthening surgery. Discuss the surgery with 2 foot and ankle surgeons. They've also discussed that with the physiatrist. Do you know this type of surgery to correct the turning of the foot, and what would be your concerns? Well, first of all, I love this question because it doesn't say what would you do. So, Richard, thank you very much. But yes, this is one of the alternatives. Sometimes neurosurgery surgeons do this. Sometimes, it's not that unusual for very severe surgeries. Again, surgery is always a risky kind of thing. Oh, also the other kind of surgeons that do it is in plastic and reconstructive surgery. Orthopedic surgeons might do it. So you have to find somebody who's skilled in it. Not every just because you're a neurosurgeon doesn't mean you do this kind of surgery. Just because you're orthopedic surgeon doesn't mean you do this particular kind of surgery. So you have to get a recommendation and find somebody. Again, I worry about surgery just in general. Um, they might be able to do some different kind of anesthesia at the C5 rather than putting you completely to sleep. So that would be something to find out about because then you won't have to come off the ventilator. They might be able to do some assisted kind of ventilation that's not, putting you on full ventilation. You do need to have anesthesia because your body will still react to pain. So if your body is feeling the pain of the surgery, your brain might not be, you might not be recognizing it, but your body will. And what will happen will be an episode of autonomic dysreflexia. So you want to alert your surgeon that that may happen, even if you've never had it before. That would be certainly a big problem, and you would want to talk about the healing process because if there's a lot of edema in your leg, or the leg is the furthest, foot's the furthest point of your body from the heart. So you want to make sure your circulation is good, that this will be able to heal up, and what kind of recommendations for when you can start therapy again, all of those kinds of things. How will you be cared for when you're in the hospital? Will you be in the hospital and then you go home? How will they protect your skin when you're on the operating table for a great length of time? If you have to lay on your stomach, how will that be handled? That would be another question that I would ask. Sometimes people who have to have some surgery and they have paralysis or they're paralyzed because they are having surgery and they're on the ventilator. Sometimes they'll wake up with a pressure injury right here or right here on their nose, and they get pretty upset about that. It does heal up pretty quickly, but you want to make sure all your body parts, when you at C5, you don't have to worry about paralysis on your head so much because you can feel. So it's time to move. You might worry about back here if you're on your pillow too long or your headrest. So you need to have proper pressure reducing equipment because you can't move too awfully much. But, protection of the face is very important when you're having surgery. So those are the kind of things. And don't rush into putting that shoe on. Make sure that everything's healed up because there will be swelling. So you'll want to wait till that goes down till you can get back in your shoe. So I wish you much success on that because I think that will be successful for you. And if you have to stay in the hospital, check and see who's going to do your bowel program. Will they be catheterizing you? Will they put a Foley in you? What is going to happen with that? Because, people who work in the hospital that do not work with people who have spinal cord injury or other neurological injuries. So, you might get the kind of help you need with turning and skincare and bowel programs and all that if you're on a neurological floor, but if you're on an orthopedic floor, it might not be as quick. And remember, in the hospital, the nurses are working on level of acuity. So who needs help first? So your bladder program, your catheterization, all that can wait. Your bowel program, well, I can't get that for a couple hours. That's going to mess up your bowel program for a long time. So, being sure that you get the help that you need is going to be very, very critical. There's been a couple questions that people have written in, which is kind of odd that we get kind of the same question. It's completely different questions, but it was the same point. And they live in areas where they don't have um, accommodations for transportation. So, like where I live, we have a program where a little bus will come pick you up and take you to a doctor's appointment or, to get health care that you need. It's seniors and also for people with disabilities. And some people live in areas where they don't have these kind of programs. So how do they get transportation? Well, there are several suggestions, and this kind of hits a rough bump because you need to go. You need to go when you need to go. And so if you can find somebody in your community that has an accessible van or piece of equipment, that might be an option. You can check with your health insurance and see if they will provide transportation. Now, it won't be an ambulance, but they have what they call cabulances. So your wheelchair just goes in the back of a van. They would be able to help. And usually, if there's no other resources, your insurance oftentimes will provide it. But I say oftentimes because all insurances are different, but even Medicaid will help provide transportation if you need to get to a healthcare appointment. There's also telemedicine now, which has certainly opened healthcare treatments to people. And so there's a lot of different things. If you can get somebody who can lift you into a car some way, I mean, they didn't say what their level was. If you can transfer into a car or a cab, a lot of people with spinal cord injury go with their caretaker and they will transfer them into a car or cab. Uber, sometimes you can get a
Hey everybody, it looks like Linda just froze. This is Kelly. I'm running it from behind the scenes. If we give her just a moment, she will hopefully come back to us. Thank you.
Oh, sorry, we had a little blurb there. Had a little blurby going on there. I hope, oh yeah, I see the, I thank you, interpreter, because I see your hands going so you can hear me. Yay! Thank you. Um, so there's a device. Now, people don't seem to like it very much for one reason. Again, do what is right for you. It's hard to learn. However, the company has an 800 number and they have nurses there that will help you unbelievably. They can talk you through anything. They are so skilled. It's very impressive. Another thing is people don't like it so much because if they have to travel, it's like a big piece of equipment that you have to take with you. And so sometimes people don't like that. But the people who get used to it and the people who use it, they love it. And so, it's another option. It only flushes out the lower bowel, so that makes it a little more convenient. Again, it's not like an enema, it's not going to flush out the whole bowel, so it's just another option. So it's something to think about. It might be quite the thing that would be helpful. So it's just something to see what's best. What's the best way to treat AD? Number one is raise the head of the bed, get that blood pressure. People who have, and there's a question in here about somebody who has orthostatic hypotension. When you raise your head too quickly, if you have paralysis from any source, sometimes if you raise your head too quickly, you pass out. And so you have to raise the head very slowly until a person gets accommodated. You want to raise the head, and then if they're going to sit up, so that has to be real slowly done. And then if they're going to, you're going to transfer them to a wheelchair, you need to hang their legs over the side of the bed and slowly lower that till the blood pressure regulates. And this can take months of time. Now, if you wear elastic stockings, abdominal binders, that will help push the blood up to the heart, which will push it up to the top to the head. So that helps resolve that. So those are the immediate treatments for orthostatic hypotension. If you have AD, you want to sit the person up as quickly as possible because that will drop the blood pressure. So you take advantage of the complication of orthostatic hypotension. So that's the first treatment. The second treatment is to remove whatever is causing the AD. Number one cause is a kinked bladder, a kink catheter in the bladder. Sometimes you're sitting on the tube. Sometimes there's a calcium deposit in there. Sometimes a plug of something. That's the number one. Number two cause is bowel impaction. So you have to evacuate the bowel. And number three is something that's bothering the skin. There are many, many other causes. Sometimes the irritant is something's irritating the body below the level of the injury, and that can be it could be gas in the bowel. It can be heartburn. It can be a pressure injury. It can be, usually we think of them as noxious, or I call them obnoxious stimulations, but it can also happen with pleasurable kinds of things. So if you're outside and the breeze is blowing over you, it can be too strong. It can trigger AD in very sensitive people. Sexual responses can trigger AD. So there's all kinds of ways to do that to get AD. If you're having problems with the AD over and over and over again, you need to check with your doctor because there's some medications that can be taken to control the AD. But that's only with people with, chronic condition of AD kinds of things, situations. Um, oh, that was the blood pressure question. Okay. Pain management. We talked about pain management, the pain management book. There's a variety of treatments for pain management. I speak mostly about nerve pain because that's what happens in neurological injury. There's a miscommunication with the messages being sent to the brain, and it gets translated as pain. The brain can't say, "Oh, you have an itch on your toe, so you need to scratch it." So it just comes up as a message. So when you have pain, neuropathic pain, it's not pain like, "Oh, I pulled a muscle." It's not pain like, I had surgery and the incision hurts. It's a different kind of pain. And the pain management book explains all the different kinds of pain. So if you take a Tylenol, it's probably not going to help your nerve pain. you have to take medication that treats nerve pain. There are two specific drugs, which are gabapentin and pregabalin. Those treat nerve pain. That is their job. That's what they were devised to do. There are also other medications. They're pretty strong medications. So sometimes people, it takes an adjustment period and takes a while to get used to them. There's also other medications that people have found out years ago through serendipity. Things like anti-epileptic medications and antidepressant medications. They treat neuropathic pain. Now, you don't take them in the strength that's needed to treat depression or epilepsy, so you're not being treated for that. You take a much, much smaller dose, but the side effect is it treats pain. And that's kind of an interesting thing. And kind of the way they found out about it was people who had depression and were on depressive medication, antidepressants, and then they got a neurological injury. They never had pain with it because it was being taken care of. Same thing with people who have epilepsy who take these medications. So if you have a head injury or a stroke and it results in seizures and you're on anti-epileptics, those patients usually don't have or don't usually have neuropathic pain because they're already being treated for it as a side effect of the treatment of the other drugs. So kind of cool for them, I guess. But anyway, it's kind of an interesting kind of thing. So there's a lot of treatments for pain. Now, some people think like when they take a Tylenol and they have a headache and they take a Tylenol, and in a short amount of time, the headache kind of goes away. So they take their medication for neuropathic pain and they think, why isn't it going away? Well, every single case of neuropathic pain is unique. And what one person needs won't work for another, and what this person's taking is not for the third person. So it's really an experimentation process. But it's an educated experimentation process until you find the right drug for you. Now, also, if you're put on a drug, it takes 6 weeks for it to gain full effect. That is a long time to wait when you're having pain. Sometimes they will up the dosage, and over time, all the pain medications have to be upped because your body gets used to it. And so you have to take just a little bit more. For some people, it'll be like in 6 months, they need to go up on their pain medication. Some people, they might go 5, 10. I've even heard of somebody who was like 20 years into it, and they were very alarmed because they had to up their pain medication and had been working so well for so long. But it was 20 years later. They were 20 years older, and things like aging affects how your pain medication works. So there's all kinds of nuances to pain medication, but your healthcare professional takes care of people with neurological injury. They know how to treat it and they'll be able to do it, but it's not a quick fix. And again, you can supplement with non medication pain situations, doing some of those pain reduction activities. Some people, even who have very severe, I had a very close relative that had very severe neuropathic pain, took a lot of neuropathic pain medication, the big guns, the gabapentin, and but it still wasn't enough. And they would fill their day with distraction, trying to get involved in something, trying to think and concentrate on other things as one of the side treatments to helping that neuropathic pain. So it's a very delicate situation. It does not happen. Some people it does. They take a pain medication, it's just right, works out great, good. Consider yourself lucky. But for most people, it's a lot of experimentation and figuring out maybe experimentation. I like to call it educated experimentation, finding the dose that's right, finding a dose that's not too much, and just hitting that sweet spot. So, how to find a supportive primary care physician upon discharge from the rehab hospital. SEI seems very nuanced, needs an expert in pain management. So, I'm wondering what I can look for in a PCP that can manage my care. Well, you have to read about them online, find out what their background is. You can interview your doctors and get an appointment for an interview, where you go and talk to them and say, "This is what my situation is. Tell me how you would treat this. Do you have experience in this?" Now, you might not find a PCP that has experience, a primary care provider, so your regular doctor. You might not find one who is adept at all areas of neurological injury. You might need a neurologist for some things. You will definitely need a urologist for urinary care. You might need a pain specialist for that care. So people end up creating a team. They will appoint one person. It might be your spinal cord injury specialist who is coordinating all of these people and their recommendations and then giving the final verdict, because you don't want to be on one medicine from the urologist that's contradicting something from the pain management doctor. They should all work in tandem. When you are in one healthcare system, they have the electronic um, medical records, so they'll see what medications you're on and it will alert if medications aren't working together. And so even you should report any over the counter medication, any recreational drugs that you're using, anything that you are taking. You really need to have good information in your chart. No judgment, just tell them what they're doing so they can do their job well. So you might need a cadre of people, and that's what most people do. They have their PCP, the primary care doctor that is doing colds, if they get a flu, they're managing the everyday health care that anybody would have. And then they have specialists in these other areas to help them manage, but they keep their spinal cord injury specialist if you're lucky enough to have one in your town and are still connected with that. There are more people that are doing online telehealth. So you might not have a spinal cord injury specialist in your town, but maybe you have telehealth at the spinal cord center where you got your rehabilitation and you're still able to connect with those people. So that is wonderful. Or if you're in a state and there's an academic medical center, they might have a telehealth program that you connect with a spinal cord injury specialist. It's usually in the bigger systems where there's a spinal cord injury specialty hospital. They usually have those kind of programs. Here's a person that feels like they're not able to resolve what is causing the AD. And again, if you're having those chronic AD problems, you need to talk to your healthcare professional about being on some medication. Sometimes you can take medication when you have an AD episode. Sometimes you can be on a medication that will help slow those number of AD episodes. So there's a couple of different things that you can do there. Um, Does pain trigger AD? Yes, anything that's bothering your body can trigger AD. Like I said, just even the wind just blowing over your skin can do it. If you're sitting too close to the fireplace in the wintertime, or if you're out in the sun, or if you get too cold, that can trigger an AD episode. Anything can. Your computer can trigger an AD episode. The way the computer works can trigger something in your eyes. There's this whole group in the Scandinavian countries that have been studying this and have demonstrated this. I had a question on that. The computer trigger can computer trigger AD, and the person had their computer in the kitchen. It was next to the refrigerator, and so what would happen was when the refrigerator would run its cycle, it would do some kind of power surge in the computer, but you couldn't see it with your naked eye. But there was something in the backlight that was doing it. And so, anyway, I really had to do some investigation. And so I found this really legitimate academic research going on over there and in the Scandinavian countries. And clearly, that was a trigger. And so, it's just anything, a noise can trigger it. It's really anything obnoxious can trigger it. And sometimes things that are pleasurable can trigger it too. Okay, so there's a lot of questions today about spasms. We call it tone. and what kind of things to do. Can you talk about baclofen? And baclofen helps. There's a lot of other things. People are going more to with tone to the Botox injections because it doesn't go throughout your whole body. It stays locally where the spasms are. So people are a lot of people are doing that. There are medications. Doing your range of motion or stretches. Sometimes people do those in the rehabilitation hospital and therapy, and when they get home, they get busy and it takes a long time. And gee, if you have to have somebody help you, or if you're doing it yourself and you're doing it to your legs, gosh, they're heavy and it's hard work and it just takes up a lot of time to do those a couple of times a day. But it is shocking how much that helps. It really helps reduce because those muscles inside your body want to contract. The natural, if you look at my hand in its relaxed form, it's contracted just a little bit. It doesn't relax. Relax is not like this. This takes me effort to do that. I can feel that, you know, causing my hand to do that. So our bodies want to contract. If you'll see somebody who has really bad spasticity in any form of neurological disease, you might see their arm contracted in and even their shoulder contracted in. So you need to stretch out those muscles and just very gently because those muscles are looking for that feedback to be pulled the other way. And you want to very gently stretch those muscles out several times a day, at least twice a day, and maybe even more if you have a spastic episode. You can help that. Now, um, there are many different things that you can do if the tone is in your legs. Sometimes people will have like a clonic episode where their leg starts bouncing because of the spasticity. So if you can imagine, I can't make my arm into a leg here. It's like this. And if you push down on the knee, the foot's on the footrest, and you push down on the knee, it'll cause those toes to be pulled up. Or you can just pull up these toes down here, pull up the whole foot, and that will relax the whole leg. So if they're in the seated position, you can do that to kind of break that clonic bouncing spasm, and that's very helpful. Um, Leonard is worried about his kidneys and liver with medications. And yes, that is something to think about. Um, so look at the packets. If you are having have your blood work done when your doctor recommends it, because they will check your liver function, they will check your kidneys through your blood work. So make sure, and if there's any kind of discrepancy in there, they can help alter to try different medications, or see if you can get off some of your medications. Ask, what would the possibility? Some medications we need to survive, and so, you have to stay on some of those medications, but ask if there's any alternatives. Try to maintain a healthy diet. Exercising your body is very, very critical. And we're at the hour, so I'm going to have to continue on. So I'm going to answer two very quick questions. Somebody wants to know, how do you know when you're having an AD episodes? There are many symptoms. The number one symptom is a really pounding headache, but there are many other symptoms as well. Sometimes there's a thing called silent AD where there are no symptoms. Checking your blood pressure to see if your blood pressure is elevated will be the thing that you need to do. So be sure you have a blood pressure cuff and get the AD wallet card from the Reeve Foundation. That is going to be very important as well because it lists all the symptoms there. Are there some spasms that are good for muscles? Actually, spasms are not bad. They just bother people. They just, it's just an irritant. My legs moving out of control. And spasms don't really do that much to hurt anybody usually, unless they're like really, really contracted and they can't release. So you don't have to worry about that. On that note, I have to say farewell, and I'll see you coming up in November. We're going to be having a professional webinar about all kinds of advances in healthcare for spinal cord injury. So I will see you there. Thanks so much for participating today.